Hi guys, welcome back everyone to the second video on the VBQ series from medicine. In the previous video lesson, we have gone through few video-based questions. I'll give you template for few more video-based questions. And you can find more such video-based questions on the PW Meded app. Okay, so let's begin with the very first question. This is going to be our first question. A patient presented with involuntary movement. So yes, we are talking about a movement disorder here. Patient's involuntary movements are documented in the video attached. Which of the following is false about the patient's condition? So that means this is going to be the most common video-based question template where video holds some information. You have to make a mental diagnosis of what this particular condition is all about. And then the question will be asked based on that mental diagnosis that you're making. If you get the diagnosis wrong, then your answer of course goes wrong. Okay. And what we have to identify is among the given statements, which statements are false. That's what we need to identify. Okay, so let me play the video first. So here's an individual showing some involuntary movement. And we know the movement disorders are classified broadly into two groups, where you have like hyperkinetic movement disorders and hypokinetic. So when you have involuntary excess movements, it's of course an hyperkinetic movement disorder, and hyperkinetic movement disorders are further divided into rhythmic and non-rhythmic. Rhythmic is where the same rhythm or same movement keeps recurring again and again, and we have called them as tremor or dystonia. And in the non-rhythmic movement disorders, we had chorea, athetosis, and Ballismus. Hi Vivek. So now please watch the video and tell me what do you think, which kind of movement disorder it is. Am I talking about a tremor here, or is it a dystonia? Is it chorea, athetosis, or Ballismus? Okay, is it the same movement which is recurring again and again? For those who have joined late, let me read out the question again and then we will see the video one more time. So we have a patient who presented with some involuntary movements. We have already watched a bit of that video. Patient's involuntary movements are documented in the video attached. Which of the following is false about the patient's condition? So first thing I have to do is, by looking at the video, I have to diagnose what is the movement abnormality here. Okay, so can we take a few minutes to quickly discuss about the movement disorders? We have done that in the previous lesson as well. Movement disorders where there are abnormal movements are classified into two broad groups, the hypokinetic and hyperkinetic movement disorders. And you know, hypokinetic, a classical example is bradykinesia that you encounter in hypokinetic disorders. A classical example is bradykinesia that you get in patients with Parkinsonism. Bradykinesia of Parkinsonism is a classical example. Okay, then we have hyperkinetic movement disorders where we further classify them into two groups. The hyperkinetic disorders are further classified into rhythmic and non-rhythmic. Rhythmic and non-rhythmic. Now rhythmic means the same movement keeps recurring again and again, and under rhythmic we have two of them. One is tremors, and in the previous lesson we have in detail discussed various types of tremors, like the resting tremors, intention tremor, postural tremor. Another one is dystonia. Today we will focus on the non-rhythmic movement disorders. There are mainly three non-rhythmic movement disorders that you need to remember. The first one is going to be chorea. Second one is athetosis, and the third one is Ballismus. If it is unilateral, you can add hemi to any of them. You can call it as hemichorea, hemiathetosis, or hemiballismus. If it is bilateral, you can simply call it as chorea, athetosis, and Ballismus. Now it's pretty easy to describe the rhythmic movement disorders because the same movement keeps recurring again and again, and we can compare it to some day-to-day event and easily describe it. Like for example, the Parkinson disease tremor, we call it as pill rolling tremor because it looks like the patient is holding a pill between thumb and other fingers and she is rolling it. This hepatic encephalopathy tremor, we call it as flapping tremor because it looks like the flapping of the wings of a bird. The postural tremor that we get in patients with Wilson's disease, it looks like again the beating of the wings of a bird, so we call it as wing beating tremor. But when it comes to non-rhythmic movement disorders, when it comes to non-rhythmic movement disorders, it's a bit difficult to describe. Why? Because there is no one standard rhythm. The movements are random. You cannot predict where will be the position of the affected limb or affected group of muscles in the next second. In rhythmic movement disorders, it is predictable, but still we can make an attempt to describe them. So what is the usual way we describe the chorea? The chorea is described as, okay, remember, chorea mainly affects the distal body parts. It affects distal body parts and face. Okay, and the usual way of describing chorea is dance-like movements. In fact, the word chorea comes from choreography. Means it looks like someone has choreographed these movements. These are called as dance-like movements. Why they are called as dance-like movements? Because the movements keep, like, they appear flowing from one joint to other joint. Like first I do this and then this. It was flowing from elbow joint to wrist joint, and that's what we do in the dance, right? We keep moving body parts as if there is something flowing through the body. So it kind of resembles dance, so that's why we describe it as dance-like. Okay, and also remember, the movements in chorea are generally rapid. They are not very slow movements. Okay, in case of athetosis, athetosis also affects distal parts, means hands, and if it is lower limb involved, then maybe feet, but proximal parts are not affected. It mainly affects the distal body parts. But unlike the chorea, these movements are slow. These movements are not rapid. Athetosis movements are not rapid, slow. And the best way to describe them is, we would rather call them as writhing movements or snake-like movements. Writhing or snake-like movements. So these are more of twisting movements. It looks like something is being constantly twisted, like how snake moves. If there is distal body parts where you see twisting movements occurring and they are rather very slow, they are not rapid, then you will call it as athetosis. And now how do I describe Ballismus? The best way to describe Ballismus, again remember, Ballismus predominantly affects the proximal muscles than distal. So the movement is not going to happen in the, like, small joints of the hand or forearm. The movement is mainly going to happen in the proximal group of muscles, like the shoulder girdle muscles and arm muscles. So what are the main functions of shoulder girdle muscles? Like deltoid is the main muscle, right? So what are the main movements that can occur at the shoulder joint? So you will be seeing the movements there, the proximal muscles, and these are usually described as violent flinging movements. Violent flinging movements. So these movements are not like gentle movements that you get in case of chorea. Chorea are literally like some classical dance kind of movements, very gentle movements. So here the proximal group of muscles showing violent flinging movements. Now fling means what? Fling basically refers to take something and then throw far away from our body. That's what the fling means. So it looks like they're trying to fling the body parts away, and that won't happen by small muscles of the hand contraction, right? I have to contract the proximal muscles. That is where I can execute the flinging movements. So whenever you get a non-rhythmic movement disorder video, first thing you should see is whether the main driver of the movements is proximal muscles or distal. If you see they are proximal muscles, probably the question is about Ballismus. But if it is distal muscles, then it is going to be chorea or athetosis. Then you should see whether the movements are kind of twisting movements and are slow. In that case, it is athetosis. But if the movements are rapid and they appear to flow from one joint to next, kind of dance like, then it is going to be chorea. So now can we see this video? Is there any involvement of shoulder joint? No. So it's not proximal group of muscles which are affected. So I'm not thinking about Ballismus here. I'm going to think about athetosis and chorea. The movements are rapid, they are not slow, and they appear to flow from one joint to other. Like you can see elbow showing some movement, and then wrist joint showing some movement, then hand joints, small muscles of the hand showing some movement, again elbow, wrist, and small muscles of the hand. So this is typical of chorea, flowy movements. It looks like someone has choreographed. I can probably relate to some Bharatanatyam or Kathakali, Kuchipudi movements. The same kind of movements they do, right? But of course, they are doing gracious movements. These are involuntary here, but kind of comparable. So that's why we are going to call them as dance-like. So yes, many of you got the diagnosis right. This video plays chorea. So once the diagnosis is sorted, now can we answer the question? What they're asking is, which of the following statements are false about the condition? Okay. So first thing is, a lesion in caudate nucleus is likely to produce the involuntary movement showed in the video. True or false? True or false? Diagnosis is right, that's chorea. The first statement, caudate nucleus is the site of lesion for chorea, true or false? Well, I definitely want you to remember the site of lesions for all the movement disorders. So on one side we will write the movement disorders, and on the other side we will write the site of lesion. Site of lesion. Okay. The first most important one is the pill rolling tremor. Pill rolling tremor. And what is the site of lesion for pill rolling tremor? You get that in Parkinson's disease, and the site of lesion is going to be substantia nigra pars compacta. Substantia nigra pars compacta. Okay. The second one is action tremor or intention tremor, that you get whenever there is a lesion in cerebellum. Cerebellum. Okay. The third one is chorea. Chorea occurs whenever there is a lesion in caudate nucleus. Easy to remember, C for C. C for C. Caudate nucleus. Caudate nucleus lesion produces chorea. Okay. The next one was athetosis, where you have distal movements but slow and twisting or snake-like movements. And the site of lesion to produce athetosis is globus pallidus. And or the putamen, globus pallidus or putamen. And the next one is the Ballismus, where you have violent flinging movements mainly occurring in the proximal group of muscles. This is what the patient will be doing. Movement is occurring at the shoulder joint usually. And the site of lesion for that is subthalamic nucleus, also called as subthalamic nucleus of Lewis. That's the site of lesion. Okay. Now, how do I remember the Ballismus as the subthalamic nucleus as the site of lesion for Ballismus? That's pretty easy and simple. Please remember, there's a cricketing shot which is also literally a violent flinging shot, where the movement mainly occurs at the shoulder joint and there is barely any movement occurring at the elbow joint. Otherwise, most of the cricket shots, you talk about square drive, right? Any cricketing shot, elbow is the main driver, but there is one shot where the main driver is the shoulder muscles. Elbow joint doesn't move much, and we call it as helicopter shot, right? Who plays that helicopter shot? The first helicopter shot was played by Muhammad Azharuddin, but the one that popularized it is Dhoni, popularly called as Tala, right? So whenever the ball comes to cricket pitch, Tala comes to play there. Ballismus, ball is in the pitch, Tala has to come there. So you remember it as subthalamic nucleus as a site of lesion for Ballismus. So that means the first statement is true. Caudate nucleus is the site of lesion for chorea. Okay. Second, patient is suffering from postural tremors. True or false? This patient had a non-rhythmic movement disorder, not a tremor. Tremor is a rhythmic movement disorder. So this is a false statement. Okay. Next one is hyperglycemia is one of the causes, right? So we should remember the causes for chorea. Few are very popular causes, few are not very popular. In fact, the most common cause is hyperglycemia. So uncontrolled diabetes can lead to caudate nucleus damage, mainly demyelination in the caudate nucleus, and that can lead to chorea. That's the most common cause. The popular causes are not very common. One of them is Huntington's chorea. Huntington's disease or Huntington's chorea. The other one is Sydenham's chorea. Where do you get Sydenham's chorea? Sydenham's chorea is a major criteria for rheumatic fever, right? So these are the common causes that you need to remember for chorea. So hyperglycemia is one of the causes, not just one of the causes, but indeed the most common cause. So this is true statement. Sodium valproate can be used for symptomatic relief. Yes, in patients where we have chorea, to relieve the chorea, we do use sodium valproate. So this is also true statement. So we are looking for a false statement, and that's there in option B. So that becomes our correct answer. Okay. Now let's go to the next question. A known diabetic presented with tingling numbness in both feet. His walk revealed abnormal gait seen in the video. Which of the following is true about the condition? There are two things here. One, he has got tingling numbness, and then the gait is abnormal. Which of the following is true about the condition? Okay, so let me play the video so that you can recognize the gait, and then we will talk about the question. So what do you notice here in the gait? Yes, first thing you can observe is patient needs support with a stick to walk. Second thing, probably it looks like he has got foot drop, and that's why he is raising his feet quite high on the ground and then stomping to avoid tripping over. So this kind of a gait, we call it as high-steppage gait or stomping gait. Where do we get that? Generally, we get it when there is foot drop. Foot drop occurs when you have weakness of distal muscles of the feet, right? Mainly the tibialis anterior and other smaller muscles. Okay, unilateral foot drop can occur because of a particular nerve damage, but here we are looking at bilateral, so it has to be a systemic disease. So which systemic disease causes distal muscle weakness? It is mainly peripheral neuropathies. Peripheral neuropathies. The muscle disorders like Duchenne muscular dystrophy or endocrine myopathies, they affect the larger proximal group of muscles, but peripheral neuropathies affect the distal smaller group of muscles. So in the upper limb, patients can develop wrist drop. In the lower limb, patients can develop feet drop. Okay, so we can conclude that we saw a high-steppage gait, and being bilateral, I am thinking of not an individual nerve injury, but rather peripheral neuropathy. Peripheral neuropathy. Okay, so once you have peripheral neuropathy, the first question is, what is the most common cause for peripheral neuropathy? Diabetic neuropathy is the most common cause for peripheral neuropathy. Okay, so now what they are asking? They are asking true about the condition. Patient is suffering from sensory neuropathy. True or false? Patient is suffering from sensory neuropathy. True or false? Is there any involvement of sensory involvement? Yeah, so if I had got a unilateral foot drop, I would have thought of the CPN nerve injury. But because it is bilateral, we would be thinking of more of systemic pathologies. So CPN, in peripheral neuropathies, generally length-based involvement occurs. The longest nerves, which are carrying the longest journey, they get affected first. Okay, and CPN, yes, carries a very long journey from the lumbosacral region all the way to the small muscles of the feet and the leg. That's why it gets affected first. See, I wouldn't consider this as a pure sensory neuropathy. Why not? Because yes, these tingling sensations are suggestive of sensory symptoms. There is involvement of sensory. But then there is also bilateral foot drop that we have noticed. And bilateral foot drop indicates that it is not only sensory, there is also involvement of motor. So there are both motor as well as sensory symptoms present. So I have to call this as sensory motor peripheral neuropathy and not pure sensory or pure motor. Okay, so we'll keep this reserved. Gait demonstrated is festinant gait. This is clearly a false statement because what we saw is the high-steppage gait. The festinant gait is the gait that we see in patients with Parkinson's disease. In patients with Parkinson's disease, where because of the increased tone of anterior muscles, they have a stooped forward posture. And because of the stooped forward posture, they have a tendency to fall forward. To escape falling forward, they make certain gait adaptations. They make their feet placement wide and they tend to walk hurriedly. That's an escape mechanism trying to avoid falling. And that kind of a gait we call it as the festinant gait or short shuffling gait. So this is false. Gait demonstrated is high steppage gait. Yes, this is true. This is what we have seen here, also called stomping gait. Patient is suffering from diabetic motor neuropathy is false, because here both the sensory and thing put together, I would rather consider this peripheral neuropathy as sensory motor. Sensory motor. In fact, in diabetic neuropathy, sensory gets affected first and eventually motor gets affected. Initial presentation is always with sensory symptoms. He is a known diabetic, so his diagnosis was uncontrolled diabetes resulting in sensory motor polyneuropathy. Okay, so we were looking for a true statement. This is not pure motor, not pure sensory. We got the true statement in option C. We are dealing with high steppage gait here. Okay, next one. The test demonstrated here helps to identify. Okay, I'll play a test. You should see the test and then tell me which of the following finding it helps to identify. Just give me 1 second. So what is this test called and what is it actually done for? What are we trying to identify by doing this test? If you look closely, the patient is holding his thumb and index finger wide open at the beginning of the test, and after that he's tapping it repeatedly. The instruction given to him was keep it as wide open as possible and then tap as fast as possible. As fast as possible. So what do we call this test as? Well, the test is called as finger tap test. The test in the video is called as finger tap test. Finger tap test. It is not for the coordination of the movement. This is done to identify bradykinesia. Bradykinesia is one of the manifestation of Parkinsonism. Okay. Now, when the bradykinesia is severe, patients themselves will complain, and then you will see bradykinesia in everything. They will be slow in everything, facial expressions gone, small handwriting, all those typical findings appear. But if I want to recognize it way before the bradykinesia becomes overtly apparent, then we do this finger tap test. Normally, a healthy individual with good motor activity should be able to, we generally ask them to do it for 10 seconds and then we count how many taps they do. They should be able to do comfortably anywhere above 45 taps in 10 seconds. If it is less than 30, that means there is bradykinesia present. Okay, understood? So we do this for 10 seconds. 10 seconds, and if the number of taps less than 30 taps and more than 45 taps, if they are able to do more than 45 taps, then there is no bradykinesia. And if they are doing less than 30 taps, there is clearly bradykinesia present. Between 30 to 45, it's a gray zone. We have to look at the clinical context and then decide whether I should count this as bradykinesia or not. But less than 30, we take it as bradykinesia. Okay. Brain fog is basically a cognitive arrest where suddenly the thought process gets blocked. Nothing to do with this motor movement. For coordination of movement, mainly we do tests like finger nose test or knee heel shin test. Intention tremor, we ask the patient to do any voluntary movement and see whether the tremor kicks in. So what we saw here is the test done for identification of bradykinesia, and we call this as finger tap test. Okay, clear? It's one of the easy early way to recognize the motor slowing or bradykinesia in Parkinson disease suspected cases. If you follow them for few more years, then the other manifestations will become apparent, but the finger tap test becomes slow much before that. Okay, so next question is this. A known hypertensive with dyspnea on exertion. Patient is hypertensive, is having shortness of breath on exertion. Examination revealed a BP of 160/60. Do you see anything abnormal in the BP here? Anything unusual in the BP? What is the pulse pressure here? In this case, is a known hypertensive. Remember, hypertension increases the risk of a lot of problems with respect to heart. Hypertension can lead to left ventricular hypertrophy. Hypertension can lead to heart failure with preserved ejection fraction. That can lead to pulmonary congestion. That can cause dyspnea. Another thing you have to remember is hypertension is also one of the leading causes for aortic regurgitation. Okay. Yes, BP is increased, but diastolic is lower and systolic is grossly increased. So if you calculate the pulse pressure here, what is pulse pressure? Pulse pressure is the difference between systolic BP minus diastolic BP. So in this case, the pulse pressure turns out to be 160 minus 60. That's almost equal to 100 millimeters of mercury. Normally, we have a pulse pressure around 40 millimeters of mercury, plus or minus 10 this side, that side. So clearly, there is increased pulse pressure. Now tell me, in what all conditions we can get wide pulse pressure? Yes, we get wide pulse pressure in patients with aortic regurgitation and hyperthyroidism. These are two important conditions you need to remember. There are other conditions, but these two you cannot miss, right? Please remember causes for wide pulse pressure. First one is aortic regurgitation and the second one is hyperthyroidism. Okay, now there is a displaced apical impulse. That means either there is eccentric LVH or left ventricular dilatation. That's why the apical impulse is displaced. Plus an early diastolic murmur in the left third intercostal space. Left third intercostal space is your Erb's area. And we use Erb's area for listening to the murmur of AR. And is this the murmur of AR? Yes, in aortic regurgitation, we get early diastolic murmur. So don't you think the diagnosis is pointing towards aortic regurgitation? Yes, the diagnosis is pointing towards aortic regurgitation. Now we have to just watch the video and answer what sign is being demonstrated. So because of this wide pulse pressure, a lot of pulses become visible in aortic regurgitation. Like you will have visible uvula pulsations, you will have visible forehead capillary pulsations, you will have visible carotid pulsation, you will have visible brachial artery pulsation, you will have visible nail bed pulsations, and we have given name for all these signs. Till now, the named signs in AR were asked as like match the following or which of the following is not or is a finding in AR, those kind of questions. But now you can expect video based questions as well. Okay, so let me play the video and see if we can identify that. Just give me 1 second. So this is a very popular video. I think all of you would have seen this. What do you notice here? Already the context is set. The context is we are expecting a patient of AR here. And if it is a case of AR and you see some visible pulsations in the neck, what should you conclude? You would think of it as dancing carotids. And what is the name given to dancing carotids? Yes, it is Corrigan's sign. It is Corrigan's sign. What is de Musset's sign? What is de Musset's sign? And let me tell you an important tip. There can be JVP based questions where some neck pulsations will be visible. There can be AR related questions where neck pulsations will be visible. In both the cases, it can be very confusing. If I have a real patient, I can see whether it is coming from an artery or vein, whether it is compressible or not. But then when it is a video, I cannot examine and see, right? I have to rely on visual inspection. So in such cases, the context helps you to differentiate whether the question is about a JVP abnormality or whether the question is about the aortic regurgitation. Okay, in this case, the context is set. It is aortic regurgitation. So I'm not talking about a JVP abnormality for. Yes, the head bobbing or head nodding is what we call as de Musset sign, again encountered in patients with aortic regurgitation. Okay, what is frog sign? What is frog sign? In the JVP, we get something called as Cannon A waves. What are Cannon A waves? Very tall A waves which appear intermittently. Typically encountered when there is AV dissociation, when atria and ventricle are contracting on their own rate and rhythm. Sometimes atria and ventricle end up contracting simultaneously. So when both of them contract simultaneously, atria will not be able to transfer any blood to the ventricle. So atrial pressure rapidly rises and gives you a very tall A wave. The next contraction, atria may be contracting first, transferring the blood to ventricle, and then ventricle contract. That time you get a normal size A wave. So these intermittently appearing tall A waves, on the JVP we call it as cannon A waves, and those A waves may be visible on the neck as intermittent vein pulsations. In that case, we will call it as frog sign. So frog sign is nothing but visible cannon A waves, visible cannon A waves, and you get those visible cannon A waves. Any condition there is AV dissociation, AV dissociation, and it was typically described in patients with, it was described first in patients with AV nodal reentrant tachycardia or AV-NRT. Okay. Now what is this Lancisi sign? Lancisi sign refers to fusion of C wave on the JVP with the V wave that is seen in patients with tricuspid regurgitation. Okay. Now similar neck pulsation videos might be coming up, which may be actually be a case of Lancisi sign or frog sign. Just go through the context and then decide what should be your answer. Okay. A similar video, but then the context is suggestive of tricuspid regurgitation, pulsatile liver, right-sided symptoms, raised JVP, hepatomegaly, ascites. Then choose Lancisi sign. Sudden onset palpitations, breathlessness, brought in a shock state. Then it could be an arrhythmia. Then if there is neck pulsation visible, think of it as frog sign. So context plays an extremely important role, and we keep telling this again and again. Even in real patient management, history plays an extremely important role, right? An isolated finding does not lead to efficient diagnosis and management. Okay, now let's go to the next question. The test demonstrated in the video helps you to identify which of the following pathology: dysmetria, intention tremor, motor apraxia, akinetic, mutism. So let me play the video, a very popular one. All of you have done this test. Okay, just give me a second. So what is this test? We simply call it as finger nose test. We have been told that this test is done to identify incoordination of movement. This is the test for coordination of movement, which is largely correct, but exactly what are you looking for when you do this test? Exactly what are we looking for? So video played finger nose test. It is a cerebellar function test. Cerebellum helps you to coordinate the movements. How does it help you to coordinate the movement? The cerebellum receives the inputs from the spinal cord. If this is cerebellum, it receives the inputs from the spinal cord through what you call as spinocerebellar tract, mainly getting the proprioception. It also gets the inputs from the motor pathway, motor cortex, and it also gets the input from the vestibular apparatus. So constantly the cerebellum is monitoring the body's position, because it is getting to know the position of different joints. It's also getting to know whether you are tilted or balanced with the help of vestibular apparatus, and motor cortex is also giving the information. So it is getting the information from higher centers as well as spinocerebellar tract and vestibular apparatus. And because it is getting all this information, it can help you to coordinate the movement. Motor area can fire and send a signal to contract a muscle to get an voluntary activity done, but voluntary activity is not gross, it is fine. To give you an example, in front of me there is a cup. If I want to grab that cup, my motor area will send the signals to the required muscles. But do you think it's only one muscle which is going to contract to get me the cup? No, multiple muscles, right? For example, right now, cup is here. So I think the first movement I should be doing is the elbow extension. When I do the elbow extension, I reach the cup. That means the triceps has to contract. Once the triceps contracts, at that time biceps has to relax, triceps has to contract so that I can reach the cup. Once I have reached the cup, I have to contract the small muscles of the hand to grab it. Once I grab it, probably I have to do an internal rotation of the shoulder, and then if I want to take a sip, the flexors of the elbow, that is mainly biceps, has to contract so that the cup reaches my mouth. So I need to coordinate, plan the movements, and to be able to plan the movements, first thing is I need to know where are my joints currently positioned. If my already elbow is extended, then I have to only contract the small muscles of the hand to grab it, right? But if my elbow is in flexed position, I have to extend it. So I have to be aware of the position of joints, which I am getting to know through the spinocerebellar tract. The sensation that it is carrying is proprioception. Body's balance is told to me by vestibular apparatus, and then motor cortex is giving the input to the cerebellum that what it wants to do. So based on what it wants to do, what is the current position of different structures in the body, we can plan and execute the movement. Okay, and one of the thing that helps me to plan and execute the movement is metria. Now what do I mean by metria? Metric means measurement. It's simple. Metria refers to ability to gauge distances. Because for the smooth movement to occur, like if I have to grab the cup, my hand should reach only the cup. It should not go beyond that. I should not extend the elbow beyond the cup, or I should not fall short of it. So I need to gauge the distance. The cerebellum, because it is getting all these inputs, can help me gauge the distance. And we are calling it as metria. If I'm not able to gauge the distance, we will call it as dysmetria. Okay, got it? So metria, or gauging the distance, is one of the functions of the cerebellum which helps you to coordinate the movement. Now what we did in the finger nose test is actually trying to see whether patient is able to gauge the distance or he has developed dysmetria. When you ask them to touch their finger and then come back and touch your finger, they have to gauge the distance. Where is your finger positioned? If they are able to gauge the distance, then they will be able to do a coordinated movement. If they are not able to gauge the distance, one thing you will notice is either they fall short of it or they go beyond the target. Going beyond the target is a frequent observation. We call it as past pointing. Past pointing. So finger nose test helps you to understand whether there is incoordination of the movement by understanding whether patient is able to execute the metria or whether he has got dysmetria. Okay, so the first and the most important answer here should be dysmetria. Okay, but the test also helps you to identify the presence of intention tremor, because in cerebellar dysfunction, they may not have the tremor at rest. They may not get the tremor when the limb is held in a particular posture, but when they try to do a voluntary movement, they cannot get the coordination right, and then they start pointing here and there, and that's exactly what is our intention tremor or action tremor. So the same test can help you to gauge the dysmetria by looking at past pointing, and the same test helps you to unmask the presence of intention tremor. Like the moment they try to touch the nose, the finger goes here and there. That is your intention tremor. When they come to your finger, again it goes here and there. That's intention tremor. They go beyond the target, that is past pointing. So dysmetria manifests on the test as past pointing. And you can also identify intention tremor. Towards the target, the tremor kicks in. So both are right answers here. If you have to choose one, I would always choose dysmetria over intention tremor, because for intention tremor I can ask them to do any voluntary action and it will come. But to prove the past pointing, I have to first have a target and then ask them to reach it. When they are going beyond that, there is dysmetria. Okay. Now can anybody tell me what is apraxia and what is akinetic mutism? What is motor apraxia? Okay, so in neurology, the word apraxia refers to loss of learnt or acquired skills. So when we lose a skill which you have already got, then we call it as apraxia. For example, as a child, as we start passing through milestones, we learn to make a tower of 3 cubes, 4 cubes, right? So now I could make a tower with 3 objects. It's a skill. I have learnt it during my childhood, and pediatricians have called it as a milestone. I don't remember by what age a child is supposed to make a tower of 3 cubes. I guess 3 years. It's a skill that I have acquired. But now if I'm not able to do that, you give me 3 cubes and I cannot arrange it like a tower, that means an acquired skill is lost. That's apraxia, right? So apraxia refers to loss of acquired skills or learned skills. Okay, more on the apraxia we'll discuss in the next video based lesson, where we will have few apraxia based videos as well. Okay, the next one is akinetic mutism. Can anybody tell me what does that mean? Akinetic mutism. Mute means switch off, like mute. Everybody knows what is mute means. And bradykinesia is a word we are familiar. Kinesis or kinesiology refers to the study of movements. Akinetic means no movements. Tushar Goswami, absolutely right. Good. So akinetic mutism is different from paralysis and aphasia. Now, for me to speak efficiently, there are multiple areas doing their job. If you ask me a question, the question first falls on my ear, then the information goes to the temporal lobe, where we have auditory area. Auditory area first processes what did we hear, then that is passed on to the Wernicke's area to decode the meaning of what I heard. Once Wernicke's area decodes the meaning of what I have heard, now I have to give an answer. So I have to coordinate with my memory area, extract the answer, and then that answer is processed by the Broca's area. Like grammatically, the answer is organized by Broca's area by placing the required words, and that signal is now sent to the vocal cords to produce the sound. That's how I give the answer to questions asked to me. In this whole apparatus, if there is any pathology and because of that I am not able to speak, we call it as aphasia. If Wernicke's area is damaged, sensory aphasia or Wernicke's aphasia, connection, arcuate fasciculus between Wernicke's and Broca's area, if that is damaged, you call it as conduction aphasia. And if Broca's area is damaged, you are not able to produce the words, then we will call it as Broca's or motor aphasia. But if this whole speech apparatus is fine, but still the person is not speaking, then we will call it as mutism. Means he is capable of speaking, but he is not doing it. That is mutism. Similarly, for motor movements, we have a pyramidal tract. Motor area sends the signals to through upper motor neuron to the spinal cord, and from the spinal cord through lower motor neuron, the signal comes to muscles and muscles contract. In this whole motor pathway, if there is any damage and because of that I am not able to execute a motor movement, then we will call it as paralysis or paresis. But if this whole system is fine, motor area is fine, the spinal cord is fine, lower motor neurons are fine, the muscle is fine, neuromuscular junction is fine, but still the patient is not executing any movements, then we call it as akinesis. The simple thing is, for us to execute movements, there's also for us to speak, there's a constant motivation required at the level of CNS, and that motivation actually comes from the cingulate cortex. So if cingulate cortex is damaged, you will have perfectly fine motor system, perfectly fine speech apparatus, but still you lack the motivation to move and you lack the motivation to speak. So such patients, despite having all motor functions, speech functions normal, they don't speak much, they don't move much. Such condition is what we call as akinetic mutism. So absent movement and speech despite normal motor and speech system, and it is usually due to severe lesions in cingulate cortex, which is part of the limbic system. Okay, so that's it about the video that we have seen. So we have covered most of the important videos that can be asked from the neurology, apart from some physio questions that can come, like the tone examination, reflex examination. So I hope they will be covered in physio. If not, I'll do another session where we will try to cover those questions as well. So that's it from me today. I'll see you in the next class, and till then, have a good time. We're doing a video based GT on the PW Medit, and the PDF file will have the details how to enroll and how to give the test. Please go through that, because it's going to be an emerging trend. The recently concluded FMGE exam had 28 video based MCQs. So NEET PG also might have 25 to 30 video based MCQs, and if you're not getting those right, then probably you're losing a huge chunk of marks. So do give the GT on the Medit up, and we will connect again in the next class. There are few more videos that we need to cover from cardiology. There are few from GIT as well. We'll try to cover them.